a brief bit of background. There's the academic background that most of us could already know, that there's increasing need for non-pharmaceutical, non-invasive care for people with dementia and for older people in general. And that this is increasing, this need, there's more alarm about it, and that music is a particularly potentially useful, or not even potentially, we know already, there's been enough study now to know that it can affect parts of the brain that have not been necessarily affected by dementia or other cognitive issues. So, and it also can be a very big stimulant for engagement. So music, and it also acts like a language. It's another, I think of it as another form of language that's nonverbal, and most people that have late stage dementia, the words may be gone, but the music can still be there. It's also the last sense we lose when we're dying is sound. So that's another thing in its favor is with music. The other thing is, in terms of my background, I'll just say that I am a professional cellist. I worked at a think tank for 7 years as a senior research assistant in the States. It was for evaluative healthcare. And then I worked also as a music practitioner. I was trained in the States. And this is something, not a music therapist, it's different. I have much less training than a music therapist. But I'm working with healing, not curing. I'm looking at music practitioners. I was hired and working with a hospice team in the States before I moved here 5 years ago, playing for people nearing the end of life or who were very ill. Not necessarily with dementia, some had dementia, some didn't. This is a thanatology session, by the way, the one in the bottom. That is a real life session of something not that I do, but something that is also in the States and is very powerful in it, and it's happening in hospitals where they're playing for people prescriptive music based on 11th century Cluny monks for people as they're dying. They're called vigils. So my study objectives have been to explore the effects of live recorded individualized music on this very under-researched and difficult to access population, and to add to the knowledge base regarding effective research methods with older people who are frail and who have dementia. My main influences, I'll just quickly just say, were definitely the Sociology of Disability. I grew up in the 60s in Berkeley, California, where this all blossomed, and the idea that people with dementia, like the Scottish Dementia Working Group up in Scotland, and also people really nearing the end of life, that these are marginalized groups of people that in various ways now are following the route, I feel, that the sociology of the disability movement kind of started in the 60s about the barriers that they have to access and well-being. So I find that that really spurred me on. I like working for underdogs, that's always my... So this was really a way to get me very galvanized at the beginning of my thesis, even more than I already was. And the other one is that the model I'm working it on is the realist evaluation. I'm doing a very complex, anything that would have the words music, end of life, and dementia in it. Those are three, in my mind, not even definable things in some ways. So it's very complex, and the realist evaluation is great because it's basically about what works for who in what circumstances. That's the short end of what that is. That's a very short version of what it is. But that's been very helpful for me for this study. The protocol was I did in-depth interviews with 14 key informants in fields related, neuroscience, music therapy, professors of various types of doing things with palliative care, end of life. That was to help inform my study, and it was very helpful. Then I went in and I recruited from many places. Many care homes were very interested in me doing this. They were very receptive. There were only 4 in the end who had anybody who reached my criterion, because my criterion were, they had to have, first I thought they should have a diagnosis of dementia. I learned quickly that I should say in Scotland, not this country, in Scotland, they aren't let into the care homes if they've already had a diagnosis of dementia, which is its own interesting thing. So these are people who have either had a real diagnosis, official, once they moved into the care home, or an unofficial diagnosis through the care home managers and nurses. But they also needed to be, I used a somewhat troubling question, but it was the best I could do, of asking the care home managers, who became my gatekeepers, would you be surprised if this person died in the next 6 months? quite a morbid question in a way, but it was a realistic way for me to try to find people who are very frail, very simple, non-scientific, but there isn't any real scientific thing for that. So then that was hard to find people who had dementia who were at that end stage, not because there aren't many people like that in care homes, but my ethics committee, which is another whole lecture which I'm not going to go into, would not let me work with anybody who could not give direct consent, which was just kind of shows you, I mean, that's how hard it is to reach this population. Has to do with my experience and others of, it was music, it was going to be very low risk, very non-invasive. I had all these things in place. If there was any upset, I was going to stop. They had a carer in the room, and I still wasn't able to access people who couldn't give direct consent. It was very maddening. We won't go into it. So that made it very difficult, and care home staff, when I would play and give presentations, were stymied. They would be like, but she would love having this, and I'd be like, I'm so sorry, I can't do this. Families would be frustrated and couldn't figure out why I couldn't do it. So I had 12 dyads in the end. Of a resident. They happened to be between the ages of 69 and 93. They could have been any age. I didn't have any requirement in that way. And their care, who, it's a whole other topic, but the care generally was a child of theirs, but it was also sometimes a staff member. It was a great nephew in one case and a cousin in another case. I did 6 music interventions. 3 were live of me playing the cello, and 3 were recorded of me playing those same tunes or that same genre of tunes on the cello. I recorded them, sat in the room with everybody in the same kind of place with me with a speaker playing for them. So that was because and the music was chosen by the participant in as much as it possibly. I had questionnaires, I talked to family members, I played snippets of things for people, I brought in CD case covers and said, what do you think about this? And so I did what I could to find out the most likely music they would like. And the recorded versus live was because there's a lot of, or a relative amount of literature out there about looking at live versus recorded, but not the same exact music. It's often like a commercial recording of something, and then a guitarist playing something completely different. And I wanted to know, was there any difference? So analysis, this is the swamp that I've been in for the last year. It's not that pretty looking actually, but, that was my raw data, was these transcripts of these interviews, transcripts of initial and exit interviews with carers and with staff members, and 2 times 1,800 minutes of video. I'm only using about 1,800 of it because I'm not using the Zoom as much as I thought I would for right now. That's another study. I also did visual analog scales. Those are those little lines with a thing, are you happy or sad, and how much in between. I did that with the carers and the residents from at the beginning of the whole study and at the end, and I'll talk about that more. And I also did blood pressure and pulse measurements initially on both participants. Quickly I learned to do it just on the carer, and I'll discuss that. The video analysis is obviously the core of this, and I did thick descriptions. I looked at all this video, I wrote everything I saw down. I fed that into NVivo, which is a qualitative tool that then I'm just looking to find themes and things that have come up to transcriptions. There was a lot of words, a lot more words than I expected. What's in there. So I'm looking at thematic coding. I'm also using PSTEM, and PSTEM was originated from this university with Professor Brooker had a little bit to do with that. And it's now about a year old, 2 years old maybe even.
Yeah, a couple of years ago.
Yes, and its initial use is for looking at live observation with people in care homes, at people with dementia, and looking basically, I'm going to do a very short, just at when there's been, to see that they're being treated right. Is there any problems with the way they're being cared for, and going back to staff with that. And it's got a very regimented, it's very clear how you do it, and there's boxes and questions, and it's very thought out. I like it very much, but it's not, for my purposes. I spoke with Dawn, and I've changed it quite a bit because I'm using it with video. I have a lot more luxury actually in many ways because of that. And so I've been using a very modified version of it. and exploring, picking out bits of the video and kind of basically iterating with what I've found from the thick description and seeing how it's matching and seeing how this can work for video observation. And I think it can be a very useful tool, and I want to explore that further.